Good morning and welcome to our breakout session. I'm Lupe Alonso Diaz. I will be your moderator/facilitator for today. This panel is called Innovative Steps to Build an Equitable Health Workforce. You've heard a lot of wonderful quotes this morning with respect to why aren't we at zero? Health access for all. Racial concordance saves lives. There's so many different messages and concepts that we can share with you, but I hope that we're all in agreement that the issue isn't whether we should build an equitable, diverse workforce, but how we do it. And in recognizing that the question is around how we do it and how we support it and how we advance those good efforts, I am pleased and honored that I have a panel of amazing leaders on my right that have been working on this very issue. As I mentioned, I'm Lupe Alonso Diaz. I'm the president and CEO of Physicians for a Healthy California, formerly known as the California Medical Association Foundation. Our core mission is recognizing that diversifying the health workforce advances community health and health equity. So that is one strategy, clearly a very important strategy on how to do that. Why is equitable, diverse, culturally dynamic, and responsive not just competent, but how do we engage in a culturally dynamic workforce is critical to ensuring that as we ask the broader questions around health access, insurance, what does it mean, that we begin to address those issues. So again, I am pleased to acknowledge and appreciate Lisa Fisher. Her pronouns are she, her. She's the Vice President of Member Relations at Community Clinic Association of the LA County. And Van Ton Kinlavan, who is also pronouns she, her, and she's the Chief Executive Officer of Futuro Health. So the way that this panel will go in, and come on in, I promise you we don't bite. So there are plenty of seats towards the front. You can't come into a woman of color's house and not sit towards the front. So please feel free to do that. So the way that this panel will go is I want to acknowledge that we did start a little bit late, but I promise you that between now and 12:15, we will have an engaging conversation, and we will be let out in time for lunch and an opportunity to hang out with each other as friends. So the way that the panel will go is I will ask the speakers to introduce themselves, their organization, and just, again, very briefly, their organization. We're going to actually do a round robin of questions. Those questions will be a little bit more detailed with respect to what specifically do their organizations do in terms of programs, efforts, initiatives to advance an equitable health workforce. And then I'll ask a couple of questions, and I'll make sure that we have some time remaining for questions and answers. So as you hear the speakers, as you hear their discussion with respect to how they're contributing to an equitable, diverse, culturally dynamic workforce, please think about questions that you may ask. I also want to recognize that as we think about driving that equitable health workforce, there is not a one-size-fits-all. It's not supposed to be that way. In order to create a dynamic, demographically representative workforce, it means that we have to do the good work that continues to be done. It also means we need to innovate and disrupt. It also means that we need to think really differently about how we do that work. So with that in mind, I'm going to first start with Lisa and then with Van. So thank you again for being here.
Thanks, Lupe, and thanks all of you for joining us here. My name is Lisa Fisher. I'm the Vice President of Member Relations at the Community Clinic Association of LA County, CCALAC, and we are an association of 65 member health centers across LA County, and our collective health centers serve about 1.89 patients, and we have about 380 service sites across LA County. And what we do as their association is bring folks together, educate, advocate, peer, connect and relate, train, and workforce is always at the top. So I'm excited to share with you later on about the programs that we're working on.
Thank you, Lisa. Van?
Thanks, Lupe. Thanks, Lisa. So Vanton Quinlivan, I come by many names. One is that I'm a refugee, first generation, escaped from the Vietnam War. And so I know firsthand what it means to have opportunity and how transformational opportunity is to the lives of those who want to make a difference. Second is that I'm an expert in workforce development, private sector experience, but also prior to this role, I was Executive Vice Chancellor of the California Community College, driving the workforce mission of the entire system. And there was able to bring the system from seeing it as a kind of an afterthought, workforce as an afterthought, to becoming a policy priority. And in that situation, we were able to grow public investment from 100 million to 200 million to 700 million to over $1 billion under the 2 terms that I served under Governor Brown. I am also chair with Governor Newsom of the HCI, it's got such a long name, California Healthcare Workforce Education and Training Council, looking at the shortages in across California. And then my day job is CEO of Futuro Health, which is a new nonprofit, 4 years old, spun up by Kaiser Permanente and its partners to address the shortage in allied health worker. How do we produce a reliable, quality, diverse workforce to fill 60 to 65% of the roles that are in healthcare? As you know, they're essential, and there's critical shortages in those roles.
Thank you. Thank you both. And again, very honored to be here with my esteemed panelists. Before I ask the first question, just to get a sense of the room, I did say it was going to be interactive. I promise you that I won't cold call people. So just to get a sense of who is in the room, because I know you're all very wonderful people in the work that you do, just generally raise your hand if you represent a community-based organization. And you can raise your hand multiple times because I will ask a number of different questions. So community-based organizations. What about advocacy organizations? Okay. Wonderful. What about generally health service organizations, whether it's direct or generally related? Thank you. More general social services? Social services? Thank you, Jane.
Jane had her hand up every time.
As she should.
Yes.
Education? Wonderful, thank you. So the first question, thank you for participating in that. So the first question for the two of you is, share with us more specifically, how do your organizations advance equitable healthcare? What does equitable healthcare mean to you or to your organization? And what specifically do you do in order to advance that? Either you or the organization to advance that.
Oh.
Either one. Okay.
All right. So we know that health equity begins with an ethnically diverse workforce, a linguistically diverse workforce, and then of course they need to be skilled both in the essential skills, you can call them in euphemisms like soft skills, but also the technical skills, right? So the combination. And so the challenge that we have demographically as a state, but also as a nation, is that we know that our K-12 pipeline is flatlining and diminishing, just the demographics of that. And so if you have a strategy that ties into your high school pipeline, it's good, but not enough because of that trend. The other trend that we know is that the boomers are exiting with all of their great seasoned skills. And so what's left? It's your adult population. And so how do we cast the net wider into the untapped talents that are out there and bring them into healthcare in important roles in ways that then they persist in healthcare? So stories like, Tamika, who is a security guard at a hospital, her mother experienced cancer, and so she became a caregiver at home and then realized that she actually enjoyed it. She wanted to transition into a healthcare role, but didn't know how. And so when she saw the flyer for Futuro Health and saw the opportunity, she was able to embark on a unique education journey that worked for adults and became a phlebotomist. Or Justice, who lost his job during the pandemic, wanted to become a nurse, is working in a ramen noodle shop in order to make money. Well, he could right now be employed within healthcare. And so when he saw the Futuro Health possible opportunity to become a medical assistant, he took that opportunity, got the medical assistant job, got promoted, and is now working on his skill sets to become a nurse while he's in healthcare right now. Or stories like Yoshiko, who's bilingual, lost a lot of confidence because she had spent many years as a homemaker, is bilingual, didn't feel she was up to the task, but then saw the flyer for patient care representative and began to take that program. And because of the preparation, she was able to survive a panel of 5 doctors who grilled her, and she got the offer. So there's so much untapped talent out there, but it's when we did the focus group of 4 focus groups across California, including one in all Spanish, there were 2 things that were thematic. The first is that for those who wanted to get into healthcare, they couldn't figure out how to get from here to there. And then, of course, the second is that for those who made it into healthcare, especially as in these entry-level roles, they were so laden by debt, they were stuck on the bottom rung. So this is the background in which Futuro Health was created. How do we solve the allied health workforce shortage, which, as you know, in California is 500,000. It's not going to be solved by solving 25 students at a time. What we were looking to do, and we were founded by Kaiser Permanente to create a solution that helped the whole industry, was to figure out how to bring diverse adults, untapped talent, into these essential healthcare roles in a way that they would persist in these roles and the commitment to the healthcare industry.
Thank you, Vana. And I appreciate definitely the work that Futuro does. And your last comment reminded me around how even as our thinking evolves around access and equity, and 20 years ago, we used to talk about no wrong door in terms of where people should be able to access health. And really, it's a no wrong place. And the story that you provided in terms of the opportunities, both in terms of economically, as well as just from the perspective of like living the type of life that we want to live, with both humility, service, and gratitude, as well as, again, service. And it goes back to, as our population ages and diversifies, where they can and should seek health care, whether it's at home or whether it is in a health setting, how important that is. So thank you for the work that you do. Thank you. Lisa?
So at CCLAC, we're actually celebrating our 30-year anniversary. We were founded in the 90s and born out of the social unrest that was occurring at that time, and really the health centers coming together to care, provide basic health care. And, fast forward, our mission was about access. How do we expand access and really reach the folks that need it in our community? And I think now we've really increased. We talked about over 380 access points with our health centers across LA County. Is like, how do we empower, right? So how are we growing this workforce? And equity is one of our core values. It's who we are and what we believe in. And with the 2020 social unrest and things that were going on, our organization built a Combating Systemic Racism Committee. And that was something that was always a part of us, but we really named it and we're intentional about it. And I think, as we're doing, and I'm going to talk about the workforce programs that we do, that is something that is integrated at every level. Mm-hmm. Every part, from pipeline to upskilling and training, and recruitment, right? We have to do it. We heard from our early panelists earlier. And so at CCLAC, we do have sort of a compendium of services. I've been with CCLAC over a decade now, and it's grown a lot, right? We started with AmeriCorps, and now we have 4 pipeline programs that are serving FNP residents, allied health professionals, and then also students. We have an HR group, we have a workforce policy advocacy group, we also do a job board, resume bank. Wrapping around our health centers, how can we really help them? And then more recently, we launched an online e-learning system, knowing that folks need access to education and training and compliance all the time at their fingertips. And then more recently, our CREW program, which is the Collaborative for Retention, Engagement, and Wellness. And that one, we've been doing now a few times, and it's really looking at health centers at the center and what can we provide them to help grow, to create a culture that's equitable, that's just, and have that reflected in everything that they do.
Thank you. I'm going to ask you both a question about barriers, and I'm going to quote one of our board members, Dr. Tanya Spiritos, who talks about how, as an example, recruitment and retention, but really recruitment of the workforce really starts at the womb from the perspective of like the importance of maternal health in terms of advancing equity and justice. So for the two of you, whether it's been in your personal lives and or in the organizations that you lead, what are some of the biggest barriers that you see with respect to advancing equitable health workforce?
Okay.
Because, and I'm sorry, and that's because the next question, not to be answered right now, will be if you were, let's see, Governor Fisher or Governor Tonkin-Levan, if you were, or Senator or Speaker, and then I will ask you what might be some policies to advance that. But first, I'll ask you about barriers.
Yeah, well, I'd say some of the big barriers are awareness and access. If folks aren't aware of the opportunities and that this is a path that they can dream and take, they don't take it. And so I think really making sure that we're talking to folks even as young as, grade school, in our homes, how are we accessing healthcare? I didn't know. I thought to be in healthcare, you had to be a doctor or a nurse, right? And, I got my master's in social work because I found out there was a way that I could care for my community that was a path that was true to me and my passion. And so I think that's one really big piece, is just for folks to be able to see people that look like them, that have similar experiences to them, path that they can relate to. They can say, I could do that. I think also resources, funding, right? We need to have programs that really help folks if they're a first-time college student or first time in, that education path, they need some extra support. What does it look like? Is there mentorship? What are the resources to stay in? Kind of that learn and earn or apprenticeship. What are these programs? I think that not having those make it really hard to make that choice. I can't afford it, so I can't do it. And then time, right? So for some professions, I think you can turn around and get in there and start doing it right away, making that difference you want to make. But for, a physician or a nurse practitioner or a behavioral health specialist, you need time. And with that means resources and support to take that long journey. So I think a lot of folks don't have those. And so I think that those are barriers we really need to overcome.
Thank you.
So I definitely agree with Lisa in terms of the awareness, the support, and the time. I'd like to share a number of other best practices. And we were so fortunate, we were invited by the WHO to share some of our best practices last May in Geneva, as well as the National Governors Association. They had gathered 20 states. Again, we're not alone as a state. So all these states and the policy teams and the state agencies are all wrestling with the healthcare workforce. So the scale. Given the magnitude of the shortages in this workforce, is the question of scale. How do you have a scaled solution that also honors the commitment to inclusion, right? And so that was the design challenge that was posed to us by Kaiser Permanente and its partners. So when we looked at the 500,000 gap in allied health workers, we said, okay, it's possible to create another accredited institution, but putting 25 more students through each time is not going to get us to, the 1,000 solutions. So we chose a design challenge, which is how do you begin to solve at thousands at a time? And so it became a different design, and we put the onus on ourselves to try to get a solution that, for example, in year one, our target was 400 medical assistants. Year two, 800 medical assistants. Year three, 1,200 medical assistants. Okay, so now you're starting to solve for scale. And just kind of rolling it forward, what we've designed enables this type of scale, but also results in 84% ethnically diverse, 52% linguistically diverse, average age 32, okay? So I'm just fast forwarding just to show you, and this, it wasn't just medical assistant, but it became, phlebotomist, sterile processing tech, surgical tech, each year, pharmacy tech, customer service rep. So every year we add on a few occupations, take off a few occupations, depending on the labor market demand. So just a few things, and just to echo what, Lisa was saying, the wraparound services for adult learners is different. So within 24 hours of someone filling out a profile, they get a call from a success coach if they meet the minimum qualifications, and the coach begins the work with them to lay out the education, the unique education journey, the expectations and the accountability, right? And then success coaching stays with them. The other best practice is that we had to experiment with where do we put the interpersonal skills. We actually tried it concurrently with, for example, the medical assistant program, but it overwhelmed. Then we tried it on the back end, and then adults are so anxious to get into that job that they didn't want to do that part. So then we did it on the front end, and so now every year thousands, every single Futura Health scholar goes through human touch healthcare to develop 6 interpersonal skills. No lecture, no talking head. It's highly experiential, so it works for adult, and it's facilitated by an experienced healthcare worker. And that's what grounds them in the world of healthcare. And so that then when we send them to any of our education college partners, the feedback we get is that they come more polished, they come more committed, and they come more ready to learn. And so from there, there's a whole network of already vetted college partners whom we've prearranged at scale to be able to take these scholars and get their technical education. And just a note on the best practice, the reason why we can do this is because we're practicing scale. To decode it, it wasn't until I came into higher education that I realized there's an economy of scale in education too. For those of you who raised your hand and said you teach, like if you have a class that's 25 that then whittles down to 15, that whittles down to 10, you're on the cutting block, right? So if we're asking in healthcare for education to, hey, can you hire faculty? Can you get labs? Can you retrain? Can you make it adult-friendly hours? The answer is no. If you're gonna have 1 student come, 2 student come, 3 student come. But now, because Futura Health, we're dealing with economy of scale and say, here, 75 pharmacy techs are gonna come to you. 125 medical assistant students are coming to you. All of a sudden, the college is like, maybe I will make some adjustments to my programming, and so that we can move and simplify the journey for adults so that it doesn't overwhelm. So it's interesting as we've been experimenting with different combinations of best practices in workforce development, it's resulting in a sort of, our diverse communities being able to enter the healthcare workforce with the credentials, with the preparations that help them to be landing in healthcare jobs and committed to the healthcare sector.
I appreciate that both of you have acknowledged that in order to look holistically at how to develop a health workforce that is demographically representative, it is a confluence of both like retention of like who's already in the workforce, as well as really rethinking who is generally in the workforce, whether they're in the health workforce, and who might be, for lack of a better term, repurpose, who else can be, excuse me, skilled differently in order to work in those spaces in the same way that we need to think about recruiting more individuals into health. And so from that perspective, recognizing that some folks in our audience are either researchers, they're advocates, they're alleged staff, they potentially may work for a department that's working in these spaces. So if you were promoted to Governor or Secretary of Health and Human Services, what policies might you advance, or what would you want to tell them in terms of either policies to advance, or what would you tell them in terms of like, what is either the work that needs to get started right now, or we need to keep doing or do something differently? What policy, advice, suggestions, platforms might you want to present as options?
Okay, so I think we need more money. That's definitely something we want, right? And we need to put it in the right places. And I think a lot of the programs already exist. They just need to be innovative in the sense that they're changing how they're doing things, right? They're expanding. And I think, teaching health centers, we need more of those. We need to have providers, some of the productivity rates are so high. How can they take time to be training and precepting the future, right? I think investment in FNP residency or PA programs where folks come out and they just need that little bit more support to feel ready and confident to take on that, role within the health center. Again, scholarships, tuition, learn and earn, apprenticeships, those kinds of programs are really, really critical. And I think also the placement sites for residencies, like for medical students or psychiatric, students, because we need those folks. And so I think really expanding that, and did I say loan forgiveness? I'll say that again. But more opportunities to kind of get in and do it without that pressure of how am I going to sustain. And then I think one of the things we've been doing more of at CCLAC is incentivizing our health centers, right? They are understaffed. They need support, they need resources, and they need investing in helping them to build the workforce for the future as well. My list is really long, but I'll stop right there and I'll hand it over to you.
My observation is that there is a glitch in the healthcare workforce development matrix. This glitch is work experience. So it's a little bit of a conundrum, right? Everybody wants an experienced, well-trained worker, but nobody wants to put in the effort to get them experience. So I think this is an area where public policy intervention can be of help. And they can be in the form of apprenticeship, they can be in the form of work and learn, right? What is unrealistic nowadays is the expectation that our adults, for example, who have a lot of obligations and commitment, can suspend buying food and do free clinical hours to gain that work experience as a part of the requirement to finish the program or the requirement to get licensure. And especially since you know that this workforce falls heavily on women, that becomes even harder. Now, in the construction trade, you don't have to do unpaid work in order to apprentice and learn get into the trade. So I think this is the area of policy intervention where I think we have to revisit the unpaid requirement of clinical hours. We have to revisit for the employers, let's say, who are willing to lean in and give 10+ clinical slots or residency slots to build work experience for those who are coming out of school, of new programs. Maybe there's a subsidy in terms of wages or stipend. I think those types of solutions will really kind of fix that glitch in our matrix right now that is really, it's a blind spot given the reality of our communities and then the need of the workforce.
Speaking to the Matrix, and I haven't seen any of the Matrix movies, so apologies that I'm going to speak out of turn over here. But you bring up a really good point with respect to the industry and the system acknowledging the experiences, including the lived experiences that come with translating those into awesome skill sets that result in how we communicate with people, how we utilize language in a way that is beyond concordant, but it really is dynamic. And so really recognizing, and it goes back to a comment that was made earlier in the day with respect to, lived experiences really being a contributing factor in terms of how a person can excel in the work that they do. And you both also raised very important comments with respect to the socioeconomic challenges and how, particularly if we're trying to raise and develop and innovate an equitable health workforce, the diversity is an and. It's race and ethnicity, it's national origin, it's and language, it's also and different abilities. It's all these different ands. And so from that perspective, just recognizing absolutely. The world that I'm most familiar with is around the physician workforce. And what's been fascinating to see, just as an example, back to Vaughn, back to your comment, what's been interesting to see is that with a lot of medical students and physicians in general, they graduate with around right now 325 to 350,000. That is a lot of money. Now, because of inflation, 5 years ago, before the pandemic, we would have said, well, that's like the size of a mortgage. Now we can't quite say that in the same way just because of inflation and the rising housing costs. But nonetheless, if we pause and we think, 325, 350,000, it really takes a very dedicated, strategic, thoughtful, long-term planning and solutioning in order to acknowledge, wow, if I enter this profession, what is the long-term benefit, and can I even qualify for those loans? So not even before we ask the question, should I take on that type of educational debt, it is, do I even qualify? Does my family qualify for that educational debt? And so what's been interesting to note is that for, as an example, a lot of medical students, what we're seeing is both a rise in terms of individuals that are graduating with zero educational debt, which makes sense because that's telling us that there are a number of families that are coming from affluent communities and that they are able to float economically these life choices. Or what we're also seeing on the flip side of it is absolutely an increase in individuals that are graduating with more than 350,000 in debt. And the experience bears out both in terms of wonderful programs like the Steve Thompson program that HCI administers, our Cal Health Cares program, in which we talk about the diversity tax, which is that oftentimes it is individuals that are from those underrepresented communities that want to go back and serve in those underrepresented communities, but that they're having to make financial choices, they're having to make life choices. And Assemblymember Bonta and Dr. Gali talked about reimbursement rates. They talked about how to ensure that we're investing in those workforce. So I really appreciate the focus just in terms of like the humanity and the human aspect of it. So back to, the opportunities, if money were no object and you had, because we have Jeff Bezos, actually not him, he's not that philanthropic, but his ex-wife, Mackenzie, is very philanthropic. Sorry, Jeff. If money were no object, what should we be investing in? What should we focus on? You talked a little, Lisa, about the programs, they already exist and we just need to do more of. Vaughn, you talked about scaling up. What else would we do? What else should we do?
I think, thinking about that earlier statement that Trico made, thinking about the or instead of the and like who we find and invite. I think, really successful folks who work in this field are folks who do it from a place of passion and heart. I think that they're looking at the individual and really investing in them. And anybody can have that. But I think if you've had more lived experience, you come with so much of that. You know the struggle, and you come from a place of wanting to reach out and lift up, And so I think being able to really have those programs that are looking for folks, because it's easier to train skills, but it's not always so easy to train that heart. And so I think, really finding out, letting folks know that that is a skill and not a skill, but it's an essential need, right? That we need to recognize when we're doing recruitment. So that was maybe more like dreamy, but I think it's really taking the person from start to finish. I am going to be able to have my education paid. I'm going to invest. I have housing. I feel safe. My family's safe. And then knowing at the end game that, you know, these organizations have prepared to have this diversity, right? We're a place with psychological safety, with inclusion and equity at the table to make the decisions. So I think inviting those folks to the table in the planning, and then knowing that they're going to be there when folks come into those doors. So
Such good points. Thank you.
So I'll just add